Good morning, everyone. I think it's time for us to get started. Welcome to the inaugural Global Health Competition for the University of Kentucky. This is a very, very exciting time for us and for the program. We are combining two events to kick off this program. We will have one of our regular Global Health Lecture Series speakers, who actually turns out to be one of our judges, Dr. William Keck, who will be introduced to you in a minute. But first, I have an announcement that Mr. Barris wants to give.
Just a moment of your time, please. Peter Barris, I'm retired from the College of Health Sciences and continuingly attached to the Political Science Department. I just want to mention that I'll be offering a course in Cuba this summer during the May term. It's a 4-week term, but we'll spend 2 weeks in Cuba. So if you're interested, I've left information out on the table, and I'll be around for a few minutes after the presentation. We also have an information session scheduled, and you can find that information on the International Office website.
Thank you.
Thank you.
Just a couple of thank yous before we get started. I have a special thank you to the President, and not the President of UK, but the President of the United States. We contacted him about withholding his announcement on the change in policy of Cuba to coincide with our Global Health Lecture. So thank you, President, the other President, for doing that. Also, would like to just give a brief thanks to a major sponsor for this program, Dr. James Roark, who is here from Seattle, Washington. Through Jim's generosity, it's been part of the development of this program. So Jim, could you just stand up and be recognized by the group? It's a great pleasure to introduce to you the President of the University of Kentucky, Dr. Capilouto, who in turn will introduce our Global Health Lecture speaker, Dr. Capilouto. I just also want to personally thank Dr. Capilouto for his interest and his encouragement in hosting and working with us on this program. It's been a real pleasure, and we all appreciate your help, Dr. Capilouto.
It's a delight, Sam. Thank you, and thank Dr. Roark again for his generosity that gives us another wonderful occasion for students to learn and tackle the problems of our day. The University of Kentucky is a remarkable place. I say that often, and I also say it's built upon 150 years of a tradition of excellence. It also has an interesting history to me. It is a land-grant university that birthed an academic medical center about 50 years ago. I don't know how many other universities can make claim to that. I know a lot of places that had academic health centers that maybe birthed universities. But this story is interesting. Incorporated in our DNA, though, is this commitment to serve community. And it was manifest to me in a book that someone sent me before my arrival that Dr. Strauss wrote about the birth of UK's medical college. And in there, he described the curriculum. And he said, just like all curricula at medical schools across the country, it certainly taught students how to treat people heroically, one at a time. That's what physicians do. But what was fascinating about that early curriculum, it had a 6-week course in diagnosing and treating a community. That was unheard of at the time. That was population-based health before many places were even thinking about it. So the tradition continues today, and I love the question that these teams are going to tackle, dealing with the use of tobacco in India. I'm intrigued by that. I, like the speaker I'm going to introduce, after being a clinician for many years, saw the light that public health could unlock mysteries and you could treat entire communities. I went back to school in my 30s. to get my public health degree. I remember one of my early lectures about the Surgeon General's report on tobacco and its harm in the United States. It triggered all kinds of investigations to curb the use of tobacco, and that many of those early investigations didn't show any effectiveness. Time and time again. I even remember someone had done a study where they had taken, all of you in here are too young, but they used to be Mr. Potato Head. Anybody remember Mr. Potato Head? Okay. And you know, you could dress up Mr. Potato Head any way you wanted to. And one of the early versions of Mr. Potato Head had a cigarette and so forth. So they took that out of Mr. Potato Head, and then they tried to assess, did that make people think differently about smoking? Again, didn't show anything. But what happened was all those individual efforts had a collective effect. You know, the power of community-based health. So we continue in those traditions today, and I get to introduce a giant in the field of public health, Dr. William Keck. And he is Professor Emeritus and former chair of the Department of Behavioral and Community Health Sciences at the Northeast Ohio Medical University and former Director of Health for the City of Akron. He served as president of the American Public Health Association. What a fine honor. A graduate of Case Western Reserve and the Harvard School of Public Health, his career is focused on providing quality public health services, teaching community health sciences, and linking public health practice with its academic basis. This afternoon, to help set the stage for UK's inaugural Global Health Case Competition, he will lecture on the curious case of Cuba and the role of political will, not wealth, in shaping national health outcomes. Ladies and gentlemen, please join me in welcoming Dr. Keck to the University of Kentucky.
Well, thank you so much, Dr. Capelouto, and good afternoon, everyone. It seems this is a propitious time to talk about Cuba, given the President's announcement last month. It may seem strange to some that we can talk about Cuba in any positive terms. After all, we've been conditioned to believe that nothing good could ever come out of that country, and we've officially been enemies now for more than 50 years. In addition, during that whole time, we've had in place the strongest embargo against any country in the world that we've ever acted before, and we've been essentially doing our best to drive Cuba into the ground. Yet, despite our expectations that low-resource Cuba would be paralyzed, its health statistics tell another quite different story. It is a story that's largely been kept from us, called by some an enigma wrapped in mystery or a paradox. Well, what I hope to do today is remove some of that mystery and describe for you how the Cuban health system began and evolved to its current structure. I'll discuss the principles upon which it's based, the key elements of its design, the impact on the system of the so-called special period, and the outcomes the system has produced in terms of health. I'll also touch briefly on the development and functioning of Cuba's biotechnical and pharmaceutical sectors and their international program of health cooperation. And of course, I'll say something about the historic change in Cuba-US relations announced by President Obama last month. Each of those topics, by the way, could be a seminar topic all by itself, so I'll really only be able to provide a broad brush in the time available to us today, the 30,000-foot overview, if you will, but I hope it'll be enough to whet your appetite a bit to learn some more. Well, here's Cuba. It's a long and narrow country, as you all know, located in the Caribbean, 90 miles between Key West and the northern coast. about 220 miles by air between Havana and Miami. It's about the same size as my home state, Ohio, shaped a bit differently, of course, but it's about that size. And it has about the same population as Ohio, a little over 11 million. Same land area, as I said. It's almost 800 miles long. And it has surprisingly high mountains in the eastern part, over about 6,500 feet is the highest peak there. And this is that 30,000-foot view of Havana. Here is the harbor where the U.S. Maine blew up over 100 years ago. Here's Old Havana, the historic part of Havana, colonial Havana, and the rest of it, the Malecon, the drive along the coast. It's quite famous, containing a seawall that the Cubans call the longest couch in the world, which is where many Cubans spend their evenings spooning, they would say, on the wall overlooking the ocean. And of course, most Americans know something about Cuba based on rum, including that elixir of rum on the left, which is really quite a delicious drink and I think available nowhere else. We know about their tobacco. They're famous for that, famous for their beaches, famous for their music, which is found everywhere. This is in a hospital, by the way, a hospital entranceway. And I just realized I should have put pictures in here of the thousands of 1950s cars that cruise the streets of Cuba, but if you've been watching the news lately, you've seen plenty of that anyway, as Americans sort of wake up to the fact that Cuba may be a bit more of a desirable destination for them. Well, at the time of the revolution, in 1959, when the corrupt Batista government was overthrown, Cuba was a middle-income country with huge disparities in health and wealth across its provinces. Cuban medicine was well respected at its center, which is, of course, in Havana and a few other large cities, but few health services were available in the countryside. The well-to-do and the military had access to good medical care, but few others on the island did. And as you can see from the slide, average infant and maternal mortality was high, and health-related infrastructure was poor. Many Cubans were dying of preventable diseases and the principal social determinants of health that included things like decrepit housing, unsafe drinking water, poor sewage disposal, poor diet, and a general lack of education across the population. So, what happened? Well, these are the major principles of the current system that actually began to take shape in the 1950s as the Revolutionary Army treated citizens' patients in its mountainous encampment. And these principles then were refined after the revolution as the new government began to wrestle with the need to deliver on their promises, especially in the case of health and education. So the establishment of health care as free of charge and a right guaranteed by the government was stated early and later enshrined in Article 50 of the Cuban Constitution in 1976. As the health system was built, it underwent a series of sometimes radical transformations as its architects evaluated process and health outcomes and adjusted their approach. The focus remained, however, on how to best emphasize a preventive, integrated approach, prioritize vulnerable populations, provide equitable access across the country, to improve the social determinants of health, and involve the population in all sectors of society in improving health while they used very scarce resources as wisely as possible. So in the first decade, much of the 1960s was focused on crafting a national system out of many different private and governmental health services that existed, and redistributing resources, or as they would put it, rationalizing the distribution of health professionals, equipment, and supplies to provide access for as many people as possible. Private facilities were nationalized and put under control of the new Ministry of Public Health, called the Ministerio de Salud Pública in Spanish, or MINSAP would be the Spanish acronym. About 200,000 volunteers went into the countryside to teach people how to read and stay healthy in a microbially contaminated environment. Neighborhood political committees began to take on health as an issue, and they initiated vaccination campaigns, health education campaigns, and so on. But as all of that was occurring, the physician population was actually shrinking. 1/2 of Cuba's 6,000 doctors in 1959, upset with the philosophies of the new government, left the country, most for the United States, leaving just about 3,000 physicians for a population then of about 5.5 million people. Significant problems to deal with. Well, we don't have time to go into all the details of what they did, but let me tell you that after the second decade, they actually surveyed the population. The ministry did that survey, and it revealed that the process that they started was meeting with some success, but there were still significant problems remaining. While grateful to have access to care, citizens complained there weren't enough doctors and nurses, that waiting time was long and time with the doctor was short. Doctors focused more on specializing than family medicine, and care was not well coordinated. That might resonate with some of you out there. Well, as a result, the system was redesigned to focus more on professional understanding of the patient in the context of the community. Student and residency curricula were changed, and students now spent time learning in community polyclinics, sort of places where the doctors were, as health professions student numbers increased because of the ongoing development of new medical, nursing, and dental schools dealing with the manpower issue. Careful evaluation of successes and failures led to another system reorganization in the mid-1980s. This major change was dubbed a sort of revolution within a revolution by the director of the World Health Organization at the time, and is known as the Family Doctor and Nurse Program, which I assume some of you or many of you have heard of. Cuban health officials decided their country would become the first in the developing world to cover the health needs of every citizen, founded on comprehensive family practice. The plan was to provide individuals, their families, and neighborhoods with a doctor and nurse team that would both coordinate medical care and lead health promotion efforts based on evidence gathered about specific health problems in that particular community. In effect, the principles of public health and clinical medicine were combined into a single professional duo, emphasizing prevention and epidemiologic analysis with improvement of individual and population health outcomes as the central purpose. By the mid-1990s, there were about 13,500 family doctor and nurse teams in place, providing access to care across the country for essentially every Cuban. Family physician and nurse teams were assigned to live in neighborhoods where they practiced, literally next door to their patients. Originally, each team was responsible for improving and maintaining the health status of 600 to 800 people, about 120 to 150 families perhaps, generally holding office hours in the morning and using the afternoon for house calls. More recently, warranted by improving health outcomes, new economic realities due to the worldwide recession, and with thousands of family physicians now serving abroad, teams can now be responsible for up to 1,500 people, often 2 nurses and a doctor per team. And that's especially true in urban areas where there are so many family doctor offices so close together. In the rural areas, not so much. But don't miss the uniqueness here. The really important point, from my perspective at least, is that the Cuban physician is held responsible for the health status of a defined population, not just the prevention, diagnosis, and treatment of disease. I'm not sure there's any other physician in the world that has that same kind of responsibility. Now, the continuous assessment and risk evaluation or care process, or dispensarización in Spanish, which really can't be translated very well, this is the process that was adopted as a way for family doctor and nurse teams to ensure that information from the patient's medical history, physical exam, home environment, and neighborhood characteristics could be used to both monitor and affect the health of individuals and families in the team's assigned area. Citizens are expected to be seen by the doctor and/or nurse at least twice a year, generally once in the office and once at home. And they are classified individually by disease and risk factors into 4 groups. Patients with chronic illnesses are seen a minimum of once every 3 months. So the information collected is used to develop treatment plans for individuals, of course, but it's also amalgamated to produce a community diagnosis used by the team to develop their own community plan to promote health and prevent disease. And the community diagnosis must be updated every 6 months and shared with the ministry that then incorporates these diagnoses into their understanding of the national health status and their national health statistics. And that's a lot of work. This is all done by hand. There are no computers at the local level. Okay. Well, there are now about 11,000 family doctor and nurse teams, along with 336 maternity homes and 234 senior daycare facilities that complement services at the primary care level. Family physicians regularly call upon primary care specialists based at their community polyclinic to consult on specific cases with specialists who refer patients to hospital services when required. Each polyclinic, which really you should think of as a multi-specialty group practice, serves a population between 20 to 60,000 people and supports some 20 to 40 family doctor and nurse teams. And in addition to physician specialists, polyclinics offer more advanced laboratory testing, diagnostic procedures, dentistry, and rehabilitation services. Now, supervision for family physician offices is also centered in the polyclinics. They have what they call basic work teams that are composed of a leader from the polyclinic, a nursing supervisor, an internist, a pediatrician, an obstetrician gynecologist, a psychologist, and often a social worker. And they have responsibility for a specified number of family doctor and nurse offices, and those responsibilities include providing specialist advice for individual patients, reviewing the neighborhood health analysis, and evaluating the performance of the doctor and nurse. And since they're all government employees, they get annual evaluations, and the doctor and nurse evaluations have 60% of their value based on the health status of the population they serve. And all provinces have at least one general, one maternity, and one pediatric hospital, and most have more than that. So here's what they sort of typically look like. Especially in rural areas, you get buildings like this. These are buildings put up specifically. The top second floor is living quarters for either the doctor or the nurse and his or her family. That's how you get 24/7 coverage. There's always somebody there. First floor is the doctor's offices, and they're fairly simple. There's a little waiting area, a doctor's office, an exam room, a treatment room, a storage area, that's it. Okay. No computers at that level, but all the records are done by hand. So this family physician is explaining to us, in this case, the records and how she uses them to create her own community diagnosis. And of course, services are free, but the government has now made a point of letting their patients know that while service to each of them is free, it does cost money to provide it. And they've listed out here what the average costs are for some of the basic services that are provided, just to remind the Cuban population that there is money involved in this. Here's some of the treatment areas. You see sparsely furnished, usually old equipment, not many medications, the basics only, and bulletin boards with their own education, and the ubiquitous Che Guevara picture, which is found almost everywhere. Polyclinics are much larger, of course, many of them in beautiful old mansions like this that have been repurposed to hold all of the specialists and equipment that you find in a polyclinic. And you see, it is better prepared. Now, most of us would say in most of these places that they're not as well stocked as these facilities we're used to, but they serve, as it says there. Okay. And then the hospitals, well, this is the sort of Cleveland Clinic of Cuba. It's the Central Referral Hospital in Havana. And it did look, before it was refurbished, it sort of looked like this, a typical 2 to 3 bed ward. This is the Children's Cardiac Surgery Hospital, which looks sort of like equipment I think you would have found in US hospitals in the 50s and 60s. Largely it is equipment from that time. It still functions, of course. Now, any of you see Sicko, Roger Moore's film Sicko? Do you remember that he took patients to Cuba? Well, Cuba, about 10 years ago, began they started a refurbishing program for their hospitals. This is that referral hospital after it had just been refurbished. The Sicko team lucked out, or Cuba lucked out actually, because they got to Cuba and got into this hospital about 2 or 3 months after it was completely refurbished. So here's their intensive care unit, and I think it would pretty much match facilities you could find any place. Okay. Well, after 30 years of effort, the medical and health situation in Cuba had changed substantially. Physician numbers had increased tenfold, and instead of just 1 medical school in Havana, the country now had 22 medical schools. This is a country the size of Ohio, where we have a lot of medical schools with 7. They had 22 medical schools, all right? At least 1 in every province. Other profession schools had also multiplied. Health facilities were built across the country. Tertiary care became available. A pharmaceutical industry was developing, and biotechnology and genetic engineering centers were established. And things began to change. In addition to the infrastructure results, excuse me, of Cuba's health system development noted on the former slide, I think it's worth emphasizing here that the system's strong foundation on primary care has been effective in application of the clinical preventive services and improvement of the population's health. If you look at examples of more recent data from 2013, Cuba's now almost 80,000 physicians have really had an impact in both Cuba and overseas. Few can match Cuba's record of 98% full immunization by the age of 2 with 13 vaccines, prenatal care for 95% of pregnant women by the end of their first trimester, almost every birth occurring in a health facility, very low rates of infant mortality, and growing overall life expectancy. Now, as you know, maternal and infant mortality are measures often used to gauge the value of health systems around the world, so I thought it might be instructive to show you Cuba's data since 1970. As you can see, the success with lowering infant mortality has been steady and substantial, with minimal disparities between urban and rural settings. That's about a 40-year period, more or less, on the 2 slides. Maternal mortality rates have not seen the same sort of declines that infant mortality has. And while the trend line is downward, the slope is small. This issue is getting a great deal of attention now by the Ministry of Public Health, where a full analysis of causes has been completed, revealing hemorrhage and infection to be major issues, and remedial action is starting. I really like to show this chart. It's a little dated now, but it essentially shows wealth on one scale measured against health indicators on this one. Here, deaths in children under 5 years of age. And generally, what you see is what we expect, that wealth equals health. The wealthier a country, the better their health status. But there's this little exception up here. So Cuba that has, similar to Indonesia and India in terms of its per capita income, has health stats and the same holds when you use a variety of other health indicators here. It's really on a par with the developed world. I'm sometimes asked, what are the secrets to Cuba's success? I think there are a number of factors at play here that only appear to be secrets because the information embargo and, quite frankly, our own hubris have kept knowledge of them distant from us. I would argue the key factor is the constancy of political will since 1959 to adhere to the basic principles I showed you earlier. And this manifests itself in a central policy question that is asked and answered over and over again as time progresses. And that question is, what do we do now with our limited resources to further improve the population's health? Okay, same question asked and answered about every 6 months, over and over and over. It's informed by regular surveillance and analysis of successes and failures. And contrast that with national health policy debates in the US. The focus on improving health status is actualized by a proactive government that puts health professionals in neighborhoods providing access to prevention-oriented primary care at no cost to its recipients. Populations at special risk are identified and prioritized for assistance in a demonstration, I think, of a need to diminish disparities and approach services in a scientifically valid and ethical manner. I think one can also argue that centralizing health policy making, health professional education, and service delivery in one agency, the Ministry of Public Health, creates a single budget, a global budget for health, if you will, that assists greatly in the effort to spend every available penny effectively and efficiently. There are very few silos there to deal with, nothing like the environment we're used to. Well, an especially harsh test of this integrated community-based approach to providing health services came in 1989, when Cuba abruptly lost its major trading partners and foreign aid with the collapse of the Soviet Union and the Eastern Bloc. In a sort of kick them while they're down gesture, the US Congress actually passed the Helms-Burton Act that further tightened the embargo with the expectation the Castro government would fall. When you look at the slide and see some of the devastating effects of what became a prolonged economic crisis for Cuba, it's somewhat surprising the country didn't actually implode. The epoch became known as the special period in a time of peace, a euphemism for substantial and prolonged suffering of a whole population. Every sector of Cuban society was affected. Fuel was hard to come by, so public and private transportation became very limited. Electricity supply was diminished and rolling blackouts became the norm, even in hospitals. Facility and equipment maintenance was next to impossible. Medicines and supplies were even harder to come by. Hundreds of thousands, actually, of Chinese bicycles were imported to give people transportation options, which is actually one of the healthier things that happened. And there were, of course, notable impacts on health. Some of the more serious are listed on this slide. Surprisingly, however, the overall health picture of the nation was affected very little, largely because of the policies and practices that were in place when the Cuban economy crashed, and the proactive measures that were enacted once health problems arose. So listed here are some of the things done to respond to these new realities. What stands out in stark contrast to the way we respond to economic difficulties in our country is that funding to maintain health and wellness was actually increased in times of economic difficulty in Cuba. Raising the budget for health, prioritizing resources for the most needy and most ill, and anticipating the needs of vulnerable populations resulted in health status largely holding the line. Additionally, the preventive approach to primary care and the resultant good general health of the population at the time the special period began proved fundamental in maintaining that population's reasonably good health status. Now, the special period, therefore, in many ways reinforced the lessons that helped build Cuba's universal health system in the first place, including the importance of prevention, the prioritization of vulnerable populations, and the importance of the social determinants of health. Among the new issues it taught are the importance of active epidemiologic surveillance, the significance of good mental health and a feeling of well-being, and the utility of natural and traditional medicines. And all these lessons are currently in play as the Cuban health system undergoes the arduous and I would say not always smooth process of reorganization in the thick of a new economic crisis caused by the worldwide recession, the ever-present and tightening U.S. embargo, and two devastating hurricanes in 2008 and 2012. And I'll come back to that issue in a few moments. It can be argued there are a few silver linings to the U.S. embargo for Cuba. One would be the development of Cuba's biotechnology and pharmaceutical research and manufacturing sector. Remember, the embargo does not permit any wholly or partially owned American manufacturer to sell raw materials or finished goods to Cuba. Remember also that during the economic boom time in the US during the 1990s, American medical equipment manufacturers and pharmaceutical companies bought or bought into many like companies around the world, dramatically reducing the capacity of Cuba to purchase items previously available to them. They had to become more self-sufficient. As you can see on the screen, the investment in facilities, equipment, and personnel is extensive. And it will likely make the students in the audience a bit jealous to know that all education in Cuba is free to the students, from kindergarten through graduate school. And the quality of that education is quite good. They produce the scientists and technicians they need internally and take pride in their devotion to science. As you can see, the top picture here is a billboard. There are a lot of political slogans around Cuba, but this one always caught my eye. There's a bulletin board declaring that Cuba is the future of men of science, and the bottom picture is one of their bioengineering facilities. And an important side benefit in these times of economic stress is that sales of Cuban products of this sector to other countries, but of course not the US, are a major source of hard cash earnings. Given what I've been telling you, it will likely surprise you to learn that medical research in Cuba is significant, but is targeted to those areas where the impact on health status is likely to be greatest, and is carried out using what is called a closed-loop approach. Simply put, that means research, development, manufacturing, and distribution is coordinated so that all entities work together to address pressing health needs. Cuba now produces much of what it needs internally, but of course there are still many items that must be imported at usually inflated costs because of limited numbers of suppliers and long transportation lines. A number of products invented and produced by Cuba are unique, and I've listed a few of them on the slide for you. There is some expectation that President Obama's action to begin to normalize relations with Cuba may make some of these products available to patients in the US in the future. I would just point out one of the major ones of interest here is Ibuprofen, which is epidermal growth factor derivative that's used in treating diabetic foot ulcer. It increases the success of that treatment in Cuba, at least, from about 55 or 60% to more than 80%. Would be very helpful here, I suspect. There are vaccines, tumor treatments, et cetera, that are unique to Cuba. Okay. Now, just shift gears a little bit. Since the early 60s, despite its own poverty, Cuba has entered into government-to-government agreements as a form of international solidarity. To bolster health systems in countries asking for assistance using Cuban doctors, nurses, and technicians. This is sometimes done at no cost to the requesting government, but more usually the host country participates in meeting the costs or reimburses Cuba completely for its assistance. In-country responses are typically one or more of 4 types. Emergency response in the time of natural disaster. That's the Henry Reeve Battalion. We could talk about that some other time if you wish. Direct provision of primary care in or underserved areas, staffing of hospitals, and training of replacements in primary care sites and or medical schools. And the Cubans actually are directly involved in running 10 medical schools in countries outside of Cuba, plus their own now 23. If you want more information about that, I'd recommend our film called Salud, which is available through the MEDIC website, and I'll give you that at the end of the talk. Well, these activities have all helped Cuba amass a great deal of soft political power around the world, particularly in the Southern Hemisphere. Cuba has also committed itself to work with Venezuela to train 100,000 doctors for the developing world over a 10-year period, and they are well on their way to accomplishing that. In addition to training non-Cubans in some of their regular medical schools, in 1999, Cuba converted their Naval Academy into the Latin American Medical School, which they call the Escuela Latinoamericana, or ELAM in Spanish, in a Spanish acronym. I think it's the largest medical school in the world, capable of handling 2,000 students in each class. 2,000 students in each class. Only students from other countries study at ELAM, including more than 200 Americans, by the way, and they receive full scholarships to study medicine for a 6-year period. Well, by design, rather than by accident, one of the fundamental strengths shown by the system is the capacity to develop methodologies and systems to respond to emerging health problems, continued financial restraints, and paradigm shifts. This is important because the current confluence of both external and internal factors is providing impetus for a reconfiguration of health service provision in Cuba that is complicated by woefully scarce resources. 90% of deaths in Cuba are now caused by chronic disease. And even the best financed, best administered, and best equipped health systems struggle with preventing and treating chronic disease, ensuring healthy aging, and detecting and controlling infectious diseases. The global economic crisis, the need to rebuild after 2 devastating hurricanes, and the ongoing embargo further limit capacity to deal with these issues. In terms of the embargo, the UN Human Rights Council estimates that the U.S. embargo has so far cost the Cuban health system about $22 billion, that's B, billion dollars, since it was enacted in 1961. There's also an element of public dissatisfaction at work here because so many family doctors leave to serve several years overseas, and many patients are not happy to be seen by foreign doctors in training. Despite a recent raise in salary, health professional reimbursement is low. Voluntary service overseas comes with a higher salary, which is a real incentive to go abroad for a few years. Well, beginning in 2010, in response to the worldwide recession's economic impact, Cuban health authorities mandated a renovation of the provision of health services to reinforce prevention, with an emphasis on curbing chronic and emerging diseases, and to identify efficient, effective practices to help control costs and provide sustainability for the health system without sacrificing the strides they've made in population health. Specific plans are in place and are being acted upon, the major elements of which are listed for you on this slide. This is proving to be the largest change in the system since the advent of the family doctor and nurse program in the 1980s. And it's characterized by the reorganizing, downsizing, and regionalizing, that's the word, downsizing, regionalizing of health services. Actually, this is a very dramatic example of the system's sort of culture of dissatisfaction, as one of my colleagues calls it, evidenced by continuous evaluation and redesign, and it's clearly informed by lessons learned during the special period. Well, might a country that spends about 1/20th as much per person on health as the US, yet achieves similar health status, have something to teach us? I think the answer is yes. It's not so much that the Cubans have invented or discovered many new truths about how to deliver health services, but more that they've found very effective ways to apply what is known than we have in the US. Think what might happen if our national health policy debates were more about population than health, than who has the money and who wields the power. Would we be better off if we found ways to better meld medicine and public health and provide access for all to low or no-cost preventively oriented primary care? Would it help us to have a real multi-sectoral approach to addressing the social determinants of health and to find ways to break down the many silos that currently define medicine, public health, and non-governmental organizations? What would happen if we rigorously evaluated health services based on their impact on health status? Shouldn't we find ways to diversify our health professions workforce and focus students on the achievement of health as well as the treatment of disease? Well, I'll let you ponder those issues for yourselves. History was made last month when President Obama announced his intent to begin to normalize diplomatic relations with Cuba. He did not remove the embargo because only Congress has that power. He did, I believe, take as big a step as he could to change everything he has the authority to change. The diplomatic approach is definitely softer. Travel potential for U.S. citizens is greater, but remains restricted. Travel will be easier as U.S. cell phones and credit cards can be used on the island. I won't have to carry hundreds and sometimes thousands of dollars with me in the pocket. Internet access may be improved, and American travelers can once again bring home Cuban rum and tobacco. Yay! Okay. Some details of the changes will remain sketchy until all the rules are written, but change is clearly in the air, and exactly what all this means for Cuba's health system, I think, remains to be determined. The announcement was certainly a boon to U.S. diplomacy, however, in the rest of the world, especially Latin America. Now, it can be easy to over-romanticize the Cuban story, and I want to be careful not to do that. Cuba is a difficult place in which to live and work. The economic system is problematic, and they certainly have to deal with their share of bureaucracy and situational incompetence. When something isn't working, you can generally count on them to change it, however. So in conclusion, I just want to remind you that the underlying principle of health as a human right has driven Cuba's steady commitment to provide equitable, quality care to its entire population free of charge. The system they designed to respond to that right and the dedicated professionals that work in it have shown that even a poor and blockaded country can improve and maintain health outcomes on a par with the developed world. The system has served as a model for a few other countries, but one can argue that had it been adopted more widely, millions more lives could have been saved and substantial suffering ameliorated. Indeed, I think we could likely improve our own health outcomes if we could take elements of their approach to heart and find ways to apply them in our own community. So with that, I'll stop talking and just provide you with these options to learn more as a way at least to get started. So thank you very much. It's been a real honor to be your inaugural speaker for this series.
Thank you so much, Dr. Keck, for that very illuminating and inspiring talk about Cuba. We have a few minutes for questions from the audience, and I'm sure that there are some questions that some of you may have that are provoked, stirred, or encouraged by some of these remarks. So, questions? Dr. Hahn. Sure.
Thank you very much, Dr. Keck. That was wonderful and enlightening. So I'm really curious about your assessment of the, how shall I say, the great political will, for healthcare, because you had that right at the top of one of your slides. And can you talk more about the socio and political cultural kinds of contexts that might make that the case? Do you know what I'm asking? More of the cultural or the political and the social context. And for example, the work I do relates to tobacco control, and you didn't really talk at all. I'm assuming that the government owns the tobacco industry, but I don't know that for sure. But I mean, that's just one of the, but the bigger question I'm asking is really what are the socio and political kinds of contexts that might really be behind the great political will that obviously they have there for healthcare reform?
Yes, they obviously, well, there are lots of disadvantages to having a government that changes very little over half a century. And Cuba is criticized for that. On the other hand, one of the great advantages is the singularity of purpose is maintained over time. And in terms of health and education, that's been a good outcome. We can argue maybe whether that's true for other sectors in Cuban society. Now, Cuba, of course, does all this in the context of its own culture. I would argue we're trapped in our culture, a private entrepreneurial approach to most public services that is problematic for us. Cuba has a different sense. Cubans tend to trust government, especially in health and education. Cubans have, I think, in general, more of a sense of community and more of a sense of responsibility to their neighbors than is generally true in this country. And they have a population that's relatively immobile, so that these relationships exist and build over time, and they've converted their political infrastructure in defense of the revolution initially into now activities that provide support for family doctor and nurse teams, neighborhoods, and so on. So mothers in defense of the revolution now largely deal with women pregnant for the first time, having babies for the first time, and making sure that they get the support they need, and so on. Now, I can't project into the future what that's likely to mean. Obviously, the Castro regime is coming to an end. I mean, even Raul Castro is 84. There are some rumors now that Fidel is quite ill. I don't know if that's true or not. He's in his late 80s, at least. Certainly, they have a succession plan in mind. I would think that the health system would be reasonably well protected for a number of reasons. First, Cubans now expect to have access to health care exactly when they need it, almost right next door. There would be a great deal of, I think, political unrest should that change. Plus, now Cuba's international status is largely built around its health services, being 65 countries or more, tens of thousands of health workers overseas. They're really, and actually they've beat the U.S. out politically in those terms for years in the developing world. So I think chances are good that these things would continue. Now, tobacco, they have the same problem we do. Tobacco is a major industry in Cuba. Fidel used to famously smoke cigars. So they've got this dichotomy of knowing that it's unhealthy, but liking the money it produces. And so there are campaigns against smoking and so on. Maybe they're hoping to export even more of the tobacco at this moment. It'll become as much of a pariah as we are in terms of forcing tobacco exports on other countries. I don't know, but that's a difficult problem for them. The rate of smoking in Cuba is higher now than in the US, but it's lower than it was before, so they're having some success. understand that their education and health systems work together. So health education starts very early, starts really in grade school, continues all the way through high school. So there are, I think, real educational efforts made to help Cubans understand how to keep themselves healthy. That's at the core, actually, of the success of the system, because they don't have the money to deal with significant levels of chronic disease. But sure, there's some push and pull between these different factors and sectors all the time. Did I get to your question at all? I kind of rambled around there. Are there other questions?
A quick
Yes.
question. So there's a lot of investment now here.
Could you speak right into the microphone? I can't hear you.
Sorry. So there's a lot of investment now in doing population health with electronic databases here, and they seem to be doing pretty well doing this by hand. My medical assistant is actually from Cuba.
Sorry, the question was about electronic databases in Cuba?
Yes, and so could you comment on the potential or the incentives to transition to electronic records or databases to improve population health, considering that they're doing okay right now?
A long time away in Cuba, I would think. First, computers are expensive. Internet connections are quite limited. Only about 5% of the population has access to the internet. There are both political and economic reasons for that. They have their own intranet, and the major research institutions, educational health professions, educational institutions, and hospitals and polyclinics are connected that way. They actually do have some telemedicine going on, even from some of their people serving in, out-of-the-way spots in South America and Africa and Asia. But in terms of real infrastructure, it's a problem. The bandwidth is very narrow. There's no fiber optic cable to Cuba yet. As I say, I think they're both political and economic reasons for that. Yet you've got this highly educated population. 99 plus literacy rate, percent literacy rate. Professional education available to whoever can qualify. Okay? A lot of smart people. It's one driver for people leaving the country because they can get trained but can't always get jobs in the sector that they would like. Certainly can't get well-paying jobs there, unless you're in the tourist sector. So a lot will depend, I think, on both political decisions that are made in terms of how much the government is willing to open up the rest of the world to people, to Cuban citizens, and then they'll have to weigh that against the benefits in terms of increasing their own electronic capability. Certainly, the internet has been very important for them because they've been cut off from a lot of the health literature in the world. They can't afford to buy and import journals. Medic, the group I work with, actually brings a lot of journals to Cuba for them. So they like to get it electronically and then spread it, make it available through the intranet, their own intranet. So I think they have the intellectual capacity, they have the interest, they have the willingness, they don't have the resources, they may not have the political will for all that you're suggesting yet.
Thank you.
Mm-hmm.
I think we're about out of time. I'd like to thank you all for attending. I'd especially like to thank Dr. Capelouto for his support and his attendance today, and thank you, particularly Dr. Keck, for a very inspiring and illuminating discussion. So let's give Dr. Keck a big round of applause. I would like to invite all of you to, it's open for the competition tomorrow. It'll be in the new pharmacy building. It starts at 9 o'clock. And then the winners will be announced at 3:30, and there will be a reception following that for the public. So please, we'd love to see you there and love to have you participate in our competition and listen to these students give a very inspiring, I'm sure, set of recommendations concerning some issues that have to do with tobacco in India. So thank you very much.
Okay, thank you.